One of our favorite topics. We know it's the breakdown of mucus, and there are some disease states that are known for having thick, tenacious mucus. Two specific ones are cystic fibrosis and bronchiectasis, although there are obviously others. Chronic bronchitis can have rather tenacious mucus. I'll tell you a story in a second. So there's a problem with the mucociliary escalator, and it's problematic because there's a change in the property of the mucus. So the mucus is no longer this nice, thin, watery, becomes much thicker, and it also is in some cases a reduction in ciliary activity, as you see in chronic bronchitis. Three primary mucolytics we'll talk about. Yeah. Going back, remembering the anatomy, we have mucus produced by goblet cells, which are in the epithelial layer, but primarily in the bronchial glands, which are submucosal in nature. There's a gel and there's a sol layer. The gel is the sticky part on top. The sol is the one on the lower level. And this is much more watery. This is where the cilia have that motion that propels mucus. And we talked about some of the other ones that are there also. We talked about the bronchial glands having the primary function, or most of the mucus is created by the bronchial glands. That is under parasympathetic control through the vagus nerve. And mucus is what this mucus membrane. Notice there's a difference in spelling there. Mucus is the thing. M-U-C-O-U-S is the membrane. Just kind of semantics. I always worried about that. Mucus that is produced is just M-U-C-U-S. And for those of you grammarians, mucus is a noun and mucus is an adjective. There you go. The sputum is what we expectorate that contains that mucus, but also contains oral or nasopharyngeal secretions, what we typically call saliva. You don't need to know any of that. Just know about the sol and the gel layer. I don't care that you know there's 200 per cell. That's kind of, even for me, that's getting ridiculous. But there's many things, including cigarette smoke, that can paralyze the cilia. The terms of viscosity and elasticity relate to what is called rheology, which is the movement of fluids. Viscosity is a property that measures how easy or hard it is to move. So if you think of pouring of olive oil or pouring of water, olive oil is much more viscous, thick if you will. Elastic is the degree to which it returns to its original shape once its force is applied. A solid would be totally elastic that it bounces back. Ideally, we want mucus that is very elastic and has a very low viscosity, so that as it gets propelled forward, the entire thing moves forward. It doesn't kind of bend itself back. And obviously low viscosity would be an ideal for a mucous membrane. The mucociliary escalator is there primarily as a mechanism to trap particles. Also is involved with the humidification process, and to some extent the insulation process. Yeah. The composition of mucus is primarily water. So that means that the patient has to be well hydrated to replenish whatever water is being needed to make the mucus. And there's also some other things that are in mucus: proteins and carbohydrates, lipids, and a small amount of DNA. The glycoproteins are the large parts of the mucus, and they have strands of polypeptides or proteins that make up the backbone of the mucus, and they have carbohydrate side chains. And what I want you to remember is that last bullet point, that the chemical bonds that hold the mucus together, there's some that are intramolecular. They're dipeptide bonds, protein bonds, and there's some that are intermolecular between molecules, and these are disulfide and hydrogen bonds. Why do we care about this? Because different mucolytics work to break up the mucus in different ways. Why do I have that there? I don't know either. Here you can see the disulfide bonds within one strand, and then they're bonded together yeah. And this is out of your text, by the way. And you can see that mucus will find it's going to work on the disulfide bonds. Some surface active agents like water would work on these physical bonds that are present there. And pulmozyme works on the DNA, breaks up the actual strand itself. The goal is to get that mucoprotein strand dissolved. That'll make the mucus less viscous and more mobile. We produce somewhere about 100 milliliters of mucus per day. It's a disgusting thought, but it's true. Most is either reabsorbed or some gets up to the glottis and we clear our throat and swallow it. And the problem is with some lung diseases, there's a alteration in the production and the clearance in the process. Some things that increase the mucus production, primarily smoking, obviously. If I don't have good clearance, that could be because the viscosity has become greater. It's thicker mucus. My cilia have become less effective. That's what happens when smokers smoke and why they end up with a morning cough. I can have decreased mucus clearance leading to mucus plugs because it's occupying space inside the airway. You have airway resistance changes. That mucus not being cleared leads to the possibility of the mucus becoming infected. That's the cause of pneumonia. And we can also get the obstruction being so great that they have microcollapse of the alveoli. We know that there's some of these diseases here that have an increase in the volume or the thickness, either, well, yeah. We also talked about the antimuscarinics and anticholinergics causing an increase in mucus production also. Ciliary activities, multiple things that can cause that. Again, smoke being the primary one. So the way we can improve mucus clearance, first of all, is just making sure they're well hydrated. That should be job number one. Make sure that their systemic hydration is being carried out, especially if they have an endotracheal tube. Then the tendency is, obviously, you can't take anything by mouth, so we need to make sure that we are hydrating them in some other fashion. Not so much in the ICU, but certainly in the home. Anything that would promote the development of mucus and any kind of irritation to the tracheobronchial tree, want to do. Optimize tracheobronchial clearance. In some cases, that may just mean positioning the patient in a certain way. Use gravity to drain. And then using something that's going to cause that mucus to be broken up in the process. Just as an aside, you'll hear people talking about the fact that drinking milk increases the phlegm. Actually, it doesn't. And if you want a resource, there you go. So, how can we go ahead and improve the movement of secretions? One, I can increase the depth of the sol layer. Two, I can go ahead and alter the consistency of the gel layer. Or I can do something to improve some ciliary activity. It's one of the asides of what sympathomimetic bronchodilators do, is they improve that function, as do corticosteroids. First thing we'll talk about is just a simple aerosol. Bland aerosol in the sense that there's no medication, it's just water that is nebulized. To what extent it actually causes the mucus to be thinned out is probably not as great, but if there is a humidity deficit, it will certainly help in replacing that. They're also known as wetting agents, and we use typically sterile or distilled water to create these, an aerosol. Humectant, in the sense that it moisturizes, that's what kind of the word means. There is a problem with aerosol particles and asthmatics. Just having an aerosol with a particle large enough has been shown in select patients to trigger an asthmatic attack. So bronchodilating them prior to a bland aerosol therapy may be indicated. If we're just doing a breathing treatment, our normal diluent is going to be isotonic saline, so there's no fluid shift. And we talked previously about hypertonic, having a higher tonicity, causing water to be pulled out of the cell into the airway itself proper, and with the hopes of thinning out the mucus and having more of it. Expectorants, if somebody isn't having a good cough or has a dry cough, the argument is maybe we just need to have something to stimulate that bronchial gland secretion. And SSKI, the saturated solution of potassium iodide, has been prescribed for that purpose. Guiafenicin is what you probably see in a medication like Robitussin, has an expectorant in it that's going to promote a cough with mucus production and hopefully more expectoration. Cough suppressants. We know that vagostimulation causes a cough, so in some patients where it's dry and non-productive, the desire might be to suppress that cough. Run into a lot of problems with patients with lung disease who are on cough suppressants, because that cough is a natural mechanism trying to clear the mucus. Suppressing it can be a bad thing, so you got to be cautious. Also, some of the cough suppressants are narcotic in nature, like codeine, and they suppress the central drive that you may end up having. And there are non-narcotic preparations. Dextromethorphan and guiafenicin is what is in Robitussin, as an example. So we're wanting to get this mucus broken up, and we do it by one of three ways. We either weaken the intermolecular forces by breaking up those disulfide bonds. We can alter the pH to weaken the sugar side of the chain, so the glucoprotein is no longer as stable of a compound. Or we destroy the protein itself, what's called proteolysis, using a proteolytic enzyme. And the process breaks down the DNA. So 3 different ways we end up doing this. First one we'll talk about is acetylcysteine. We can deliver it as an aerosol, Well, there's a huge amount of debate of whether or not that has any effect at all. We can also instill it during a bronchoscopy. It's probably more useful in a lot of other things other than breaking up mucus. So one example is it's given IV to reduce liver injury from acetaminophen overdose. One of the problems with people who have an overdose of Tylenol, acetaminophen, is that you end up having profound liver damage. And don't know why exactly, but this drug reduces that effect. And you can see there's some other ones there. I like to reduce symptoms in schizophrenia and bipolar disorder. I've never seen it used for that, but okay, whatever you say. But acetylcysteine, formerly known as Mucomist, was the medication that was used for this purpose. And you know from your test what the dosages are. And yeah. Hazards, it has been known to, at least anecdotally, promote a asthmatic attack. So we always want to mix it with a bronchodilator, short-acting agent. It also can lead to bronchorrhea. That's a nice word for you. You think diarrhea? Think bronchorrhea. So all of the mucus glands hyperproduce, and now if you don't have a good adequate cough or suction mechanism, you can actually promote more mucus being trapped. Can't mix it with a lot of other stuff. A disagreeable odor. That's putting it kindly. It smells like rotten eggs. It's awful. And it tastes not too good either. But it's effective in some cases. So. And they come in vials that shouldn't be used for more than 96 hours. Okay. Have you smelled it? Nasty, isn't it? Second one. Acetylcysteine breaks disulfide bonds. Sodium bicarbonate changes the pH of the mucus, and in the process that polysaccharide chain starts dissolving. We typically do not use this as a or as a mucolytic. One area where it is used is in chlorine gas inhalation. It actually neutralizes the chlorine gas effect on the tissues. I don't expect you to know the dosages, but I've given them for your enjoyment, or not. I'm that kind of a guy, kind of generous. The one I do want you to pay a special attention to is the proteolytic enzyme pomazyme, also known as dornase alpha, and this is what attacks the protein component of mucus through the DNA. It's a clone of a human pancreatic enzyme. It's found in a recombinant human state, and it's used to reduce the viscosity of secretions. It has specific indications in cystic fibrosis and bronchiectasis. Those are the two most common places that you'll see this medication ordered. In fact, it's part of maintenance therapy in cystic fibrosis. It only works on infected sputum by breaking down the organisms. It doesn't have much effect on non-infected sputum. And here you can end up seeing little DNA strands being broken apart, and therefore there's less viscosity present. Thick, purulent mucus. Gotta tell you a little story here. But I gotta pause it. I'll leave it at that. It's single dose vials that they come in. It's 1 milligram per milliliter, or 0.1% solution. So there's 2.5 milligrams in 2.5 milliliters, and we administer one dose daily. Sometimes they split the dose and do it in BID administration. It's not to be nebulized with anything else. It's got a specific nebulizer. It needs to be refrigerated, protected from light. It's a kind of a cumbersome drug to work, but the cystic folks learn to end up having no problems with it. There are some side effects that can have, mainly just an irritation. And I love that it's contraindicated in patients hypersensitive to Chinese hamster ovary cell products. Just so you know. Some of you know why? Chinese hamster ovary cells are what are used in recombinant medications. That's how the medication is developed. Why Chinese hamster ovary cells? I don't know. You would know. Well, you had a bad reaction when you took a recombinant drug one time. I guess I'm allergic. We talked about this previously, that all three of these will break down the bonds in some fashion, but the patient has to be able to clear that mucus out. Whenever you use a mucolytic, one of the things to be forefront in your mind is, does this patient have an adequate cough? And if they don't have an adequate cough, they should be used with extreme caution. I won't ask you on this one, but this is kind of an interesting one that is used in cystic fibrosis. It actually is a diuretic, but it works as a sodium channel blocker, and that's important because by blocking sodium, you have the mucus maintaining hydration in the process. We don't use it, although it can be nebulized. I have never seen it used. So there you go. And that's a picture on how it works, blocking the channel. Some new ones which are potentially out there. I know you don't have it. That's okay. One day you may see Gunusful tetrasodium on the market. And there's a whole bunch of other experimental agents. This is one of the areas that they really want to get, because there's so limited number of medications currently out there. We're always looking for new things to break up mucus because lung disease is still quite prevalent. So who knows? I'm thinking I'm okay with that. Just from a personal standpoint. All right. Let me go ahead then and call up Module F, since we had to make up a little time because of that darn snow day. Nice try, Melanie. She says, I'm out of here. Let's take 5 minutes so Nikki can pee. Okay. Okay, there's three different groups of medications here we're going to talk about. Mast cell stabilizers. Then there's some inflammatory mediators that we can have, or blockers that we can have. And corticosteroids. And finally, we should have Leukotriene inhibitors. And the goal here is to reduce an inflammatory process. Okay, how about a video?
When you feel the first symptoms of a cold, use Vicks First Defense. It's a new microgel that attacks the cold virus where it starts at the back of the nose, before it has a chance to spread and develop. New Vicks First Defense. Attack is the best form of defense.
Oh. It'll probably crash on me anyway, so par for the course. I don't know why it's not giving me values there. That's weird. An easy one. Thank you. See if people paid attention. It was so long ago. Spud'em. Let's get a video. Don't you love these questions? I don't think I want to know.
She never did for clickers, so I didn't share.
Why are you answering for? Why? There's no ciliated cells. No snorting in class. Hey. Okay. When we talk about anti-inflammatory drugs, we can divide them into non-steroidal and steroidal. The steroidal, again, being adrenal corticosteroid. And the two non-steroidal anti-inflammatory are mast cell stabilizers and leukotriene antagonists. And these are guys that are working in these areas. So let's talk about inflammation. We know that there are these cells located in the both in the upper airway and in the lower airway, called mast cells. And along with eosinophils, macrophages, and basophils, they're all found somewhere in the submucosal layer. These cells contain granules that have chemical mediators within them, and during that antigen-antibody reaction, you have calcium being moved into the cell, and the release of these mediators, specifically IgE, is the antibody which is released to cause that mast cell degranulation. Some common antigens that asthmatics might be exposed to. There's a ton of them. What ends up happening when those mediators are released, you end up having then three primary actions. The first one of which is bronchospasm, causing the smooth muscle of the smaller airways to constrict. Second of all, you have vasodilation with mucosal edema developing, secondary to increased vascular permeability. And thirdly, you have increase in mucus production, which now can't be adequately cleared because the airway is narrower. And those are your three primary inflammatory responses that you see in asthma, right? Jeannie's talked about asthma, hasn't she? Covering it now. Some of the mediators are things like histamine, eosinophil chemotactic flat factor of anaphylaxis. Sure, whatever you say. Leukotrienes and prostaglandins are also mediators that are released, and there's a bunch of other ones out there too. But we're going to find that leukotriene antagonists that we're going to focus on as one of the medication types to stabilize this. So here's my mast cell. Here it's degranulating, and these things are being released, and basically it leads to all of those side effects that you don't want happening. There's two phases to an inflammatory response, and I think Jeannie may have gone through that. There's an early phase, which happens immediately upon exposure to the antigen, and there's also a late phase that happens some amount of time after the exposure. The early phase is what we typically think of an asthmatic attack: the coughing, the wheezing, the shortness of breath, the ventilation perfusion mismatching leading to hypoxemia. The late phase, though, is also sometimes masked by the primary phase or the early phase. But here's where we have the lymphocytes and other mediators coming to the area of, and what we end up then is having this hypersecretion of mucus with mucosal swelling and poor clearance. I call it a traffic jam. And that mast cell releases a substance called arachidonic acid, which produces those leukotrienes and the prostaglandins. So this is out of your text, and you can see the early phase on the left-hand side: histamine, other chemical mediators causing those bronchoconstriction, mucus production. At the same time, you have this phospholipid membrane producing arachidonic acid, which has two different pathways, one leading to development of prostaglandins, one leading to development of leukotrienes, both of which cause that late effect in the process. This might be a nice thing to kind of commit to memory. Just a hint. Okay. It's a lot of big words, but you should know that there's two different pathways, one of which leads to an early phase, one of which leads to a late phase through two different pathways. Okay, so what's the goal? Stop the mast cell from degranulating, or stop some of those inflammatory processes from continuing on. So something that might inhibit leukotriene or prostaglandin would be beneficial in treating that late phase or preventing that late phase from happening. Something that ties up histamine so it doesn't have the ability to go ahead and cause all of its damage. Corticosteroids, as we'll find, are kind of a broad spectrum. It kind of treats the whole inflammatory pathway and blocks it in multiple sites. Let's first talk about to stop the mast cell from degranulating in what are known as anti-asthmatic drugs or mast cell stabilizers. These, as I mentioned, prevent calcium influx, thereby preventing the mediator release. The drug that you need to know is cromolyn sodium. It's available as an inhalational drug as Intol. It's also available as a nasal mast cell stabilizer because there's mast cells in your nasal passage. So for those who suffer from allergic rhinitis, nasal crown is an option for there. There were some other drugs that were previously there, and there's a drug, Acetylcysteine, that is for eyes, but whether or not it'll make it into the lungs as a inhalational drug remains to be seen. These do not have anything to do with the cyclic AMP. They don't stimulate beta receptor sites, so they should not be used in an acute asthmatic attack. They seem to work best for patients with mild asthma, and I will tell you probably within a few years they'll be gone. It's not something we're going to end up seeing. So here's calcium coming into the mast cell, causing degranulation. Cromolyn blocks that process, and you don't have the mast cell degranulate. Mast cell don't degranulate, none of the other bad things happens. So we're stopping it at the beginning. It's a prophylactic, so if Joey's going over to Aunt Millie's and Aunt Millie has a cat and Joey's allergic to cats, pre-medicating him with a mast cell stabilizer prevents that allergic attack from happening. It can also be used for exercise-induced asthma, and again, it's like the long-acting beta agonist should never be used in an asthmatic attack because it has no function. This is how it's marketed. You can see it's a very old drug, comparably. This comes as a 2 milliliter ampule containing 20 milligrams, and you basically just nebulize the 2 milliliters. It was available as an MDI. That is no longer available, and like I said, I can't see this being on the market that much longer. Do you even see it anymore? There you go. Maybe I should stop teaching it. Generally, it's well tolerated. Can again have some effects as far as localized irritation, mouth. So overall, it's fine. Let's talk about corticosteroids. We know that the adrenal cortex, one of its functions is to secrete epinephrine from the medulla. But the cortex portion of it is where the adrenocorticosteroids are created. There's multiple things steroids do, one of which is it's an anti-inflammatory. It can be given orally, it can be given parenterally, it can be given by aerosol, and now it is our frontline drug in the management of asthma. The use of Pulmicort, Qvar, any of them are the primary mechanism by which we stabilize the airway. There's your adrenal gland. You know, the cortex is the outer part, medulla is the inner part. And go back in time, you may have heard of this, the hypothalamic pituitary adrenal axis. Put a star by this one. It's something you have to have a good handle on. Let's say for whatever reason my blood level of corticosteroids is reduced. The hypothalamus recognizes this. It sends an impulse to the pituitary gland, the anterior portion of the pituitary gland, which stimulates a corticotropin releasing factor, which is a hormone that is released, and that formulates the formation of the hormone adrenocorticotropin, or ACTH. That ACTH floats along in the bloodstream until it gets to the adrenal cortex. The adrenal cortex then is stimulated to produce more steroids, and the blood level of the corticosteroids goes up. So this pathway that exists is how we normally regulate the amount of corticosteroids within our body. It's a natural occurring substance. You need it for multiple functions, one of which is this anti-inflammatory process. When the levels change, this axis kicks in to be able to regulate it. There's a picture in your text, for those of you who have opened it, that basically is saying that the hypothalamus recognizes that the level of corticosteroids is low, sends an impulse, CRF creates ACTH, which then goes to the bloodstream and tells the adrenal cortex to make some more. Okay, might not be a bad idea to kind of get a good handle on that. Why do we care? Well, it's part of our natural process, and there is a circadian rhythm that's based around this. And just as an aside, off-shift workers have a horrendous time, and a lot of times, if they're asthmatic, can actually cause a little more problem with management of it. The key part is that's the second and third bullet points that I want you to pay attention to. When we give a patient steroids, this mechanism is suppressed. We trick the body into not producing steroids. And the body doesn't. Because hey, there's enough stuff floating around. I don't need to make any more. So that axis shuts off. If I abruptly stop, it can't just kick in again. It takes a little bit of time, which can lead to some very, very large problems, including death. So abruptly stopping steroids, specifically IV steroids and or oral steroids, can lead to big time problems because of that axis. Okay? All right. We call this HPA insufficiency, and this is why we have patients, especially on oral steroids, they get weaned very slowly. Has anybody ever been on oral steroids? Bad asthma attack kicked in, put you on steroids, and you went very slowly off of them, right?
Yeah, it's like 5, 4, 3, 2, 1.
Yep. I have a friend who was, doctor said, just stop taking them. I said, are you out of your mind? And she ended up having a bad reaction. So weaning it slowly allows the system to kick back in again, and it starts being shut off almost immediately upon starting systemic steroids. So how do I do it, or how do I prevent this from happening? Well, I go ahead and I spread, as Melanie said, that dosing out over a couple of days, tapering it each day as you go along, even to the extent that it can be an alternate day therapy at the end. Side effects of corticosteroids, you can see there's a ton of them. Including immunosuppressions, increased susceptibility to infections, muscle weakness, growth suppression. Sounds like a great drug to take. 2 that you should know, because I think they're just great names: Buffalo Hump and Moonface. Right. Buffalo Hump. It's called Cushing syndrome. Central obesity, moon face, the rounding of the face, and the development of fatty tissues on the back of the neck. You can see why they call it buffalo hump. It's a side effect. If your asthma is so bad that you have to be on steroids, that's the consequence, that you end up having chronic oral steroid use. Okay. Now, I am talking here about systemic steroid administration. Okay? Doesn't necessarily mean it translates into inhaled corticosteroids. Big difference. There's my moon face. So, the good news is that inhaled steroids don't affect the blood level of steroids the same way that systemic steroid administration does. So we don't have this HPA insufficiency problem going on. We also don't have as many side effects. Now, there are some side effects associated with it, but not as great. Our goal is to maintain the control of asthma, and we do it through the use of the aerosolized corticosteroids. And it sometimes takes a little bit of time for these aerosolized steroids to get their best effect. So you're not going to see it immediately in some cases. So you can see there's very low, if any, risk of steroid dependence. This growth development in children, they're kind of now saying maybe by the time you reach adulthood, you may be a ½ inch, possibly shorter. But not a real significant. I mean, it beats having asthma that's not managed well. Downside is they're a little more expensive than some of the oral agents, but they're still better off. As you can see, there are a whole bunch of them. And as you can see, on the last 8 drugs, I'm just asking you for trade name and generic names. I'm not asking you for dosages, unless you want me to. So, beclomethasone, budesonide, fluticasone, mometasone, triamcinolone. You should know the trade and generic names for each of them, and notice that all of these drugs have 3 levels: a low dose, medium dose, and a high dose. And if you look at the EPR3 that Jeannie's going through on the asthma, depending upon if we're talking about mild intermittent, mild persistent, moderate persistent, severe persistent, we change the dosages of the steroids as you go up the ladder. Okay, is this vaguely making sense? Isn't it great when classes kind of mesh together and you can? Maybe not. There are some adverse effects, the biggest one of which is a fungal infection, development of candidiasis infections. Because steroids suppress the normal immune response, the candidiasis can develop, and that's why we have the patients rinse their mouth out or ideally use a spacer. Can also have some problems as far as some irritants. As I'm transferring from systemic to aerosol, again, I got to remember to taper that systemic dosages, so there may be a need to go up on one and down on the other at the same time. And we talked about growth impairment. Like many other medications, the development of stress alters the effect of this, and this is sometimes why asthmatics need to go back on a systemic administration and wean that down because the aerosolized ones aren't working. Last group. So we talked about mast cell stabilizers. We talked about corticosteroids. Now the leukotriene modifiers or leukotriene antagonists. These again are not used during an acute attack. These are used as a stabilization. They're controller medications, not rescue medications. There's 3 primary leukotriene inhibitors: Xolutin, zafirlocast, and montelukast. I think all I want you to know is the last one, montelukast. These are all oral medications, so it's not something that we would necessarily administer. It is, however, medications that we might encounter. We talked about that mast cell degranulating, the phospholipid creating arachidonic acid, and this pathway here, the LTB, those are the leukotriene, the various leukotrienes that are present, leading to the late phase of an asthmatic attack. If I can tie those guys up, I don't have the prolonged effect that is there. Xolutin or Zyflo, again, it's an oral medication. Leave it at that. Zafirlocast, you can use only the advantages of the third one is you can use on younger kids. These you can't. And this is the one I want you to know about. Singular, you probably have heard at some point along the line. And it blocks the leukotriene receptor site, leukotriene receptor site. Downside to using these drugs, they only inhibit one mediator pathway. Doesn't do anything else. As we know, asthma has multiple pathways. Fair, receptive on the part of the patient as far as seeing benefit from it. And a lot of times we just try it to see if it works. If it doesn't work, we don't continue using it. I don't know if Jeannie talked about it or not, but they're finding now in asthma is that there are many genotypes for asthma. Asthma is not asthma is not asthma. That there's different ways the body reacts in different people. So where one drug worked great on one person, it's not going to work at all on another. One day, we'll be able to tie medications to our DNA. And that's where we'll get really cool. And we ain't there yet. Upper airway, just make mention of, you don't need to know this, but things like antihistamines block the release of histamine, therefore you don't have all that degranulation of the mast cell. There's various intranasal medications, both nasal steroids as well as nasal mast cell stabilizers, and decongestants, the vasoconstrictive agents, the ones that stop the runny nose. They're usually alpha adrenergic agents, epinephrine derivatives, and because of that, they also have a very high tolerance. Here's some intranasal corticosteroids. Gee, you think they're nasal? Flonase, nasocort. And the last one that I'll make mention of, I don't know to what extent Jeannie covers this. It's a drug that's called Xolair, because I'm not pronouncing that first one, omalizumab. Again, this is a human monoclonal antibody, and it's indicated for patients with severe persistent asthma. So these are the worst of the worst. It's an injection that is given, and it has been shown in those patients that have IgE-related asthma to reduce steroid use and even get off steroids. And this is where that one is working. And we know that there's 5 immunoglobulins that are there with IgE. You should know that by now. Is the one that's associated with the hypersensitivity reaction. It's a subcutaneous injection every couple of weeks, and we watch the IgE levels. But it's kind of an interesting medication. Xolair. These are graphic designers that have too much time on their hand.